Honorable Chair, Dr. Rakesh Shahai, Dr. Shalini Jaggi, ladies and gentlemen, a very good morning to you. I'm here to talk about RISE, which basically stands for Restoration of Insulin Secretion. And this is a consortium of studies, which obviously means that there are a number of studies which has been incorporated in this group called the RISE group of studies. All of you will agree with me that reversal of diabetes is the holy grail for any research intervention all across the world. So what we need to understand that what is the need for this RISE group of studies. And then obviously I'll very briefly touch upon the individual components of these studies and try to make a meaningful conclusion out of this. So we all are aware that we have very increasing incidence of diabetes, but we also know for sure that before that it is always preceded, in most of the cases, by a very high or increasing incidence of obesity, and obviously it is translated into more and more cases of impaired glucose tolerance and impaired fasting glucose. And this is not surprising to us because we know that pathogenetically type 2 diabetes is characterized by inexorable decline in beta cell function. Now, what is responsible for this beta cell decline is obviously a cycle of glucotoxicity, lipotoxicity, and obviously all acting in tandem lead to a progressive destruction in the beta cell. So obviously, if we want to prevent all this from happening, if we want to reverse this tide of decline in the beta cell function, or at least decelerate the tempo of this degeneration, we have to target the pathogenetic mechanism, which is obviously the cycle of glucotoxicity and lipotoxicity. Now, are the existing drugs which are available to us to treat our patients with type 2 diabetes? They can do that. And if we look at the number of drugs which we use in our clinical practice, like metformin or TZDs or insulin or the incretin-based therapies, and all of them through their independent modes of action, some of them acting on the glucotoxicity, acting upon the hepatic glucose output, hepatic insulin sensitivity. TZDs primarily act on the lipid metabolism. They improve the sensitivity in the adipose tissue and the muscles. Insulin provides the beta cell rest. So all of them have their independent modalities of action. In addition, they can prevent the progression from pre-diabetes to diabetes by improving the beta cell function. Unfortunately, at this point of time, in patients with pre-diabetes or newly diagnosed diabetes, we have paucity of data to tell us that whether giving a particular modality of treatment will arrest the progression of decline of beta cell function, or be even more important, if we do it for a year or 2 years or so, and then when we stop the treatment, are we going to reap the benefit for a longer period of time? So all these issues need to be addressed through these interventions. And in that context, both in the young patients and also in the adult patients with type 2 diabetes, this group of studies were done, and primarily they looked at giving certain strategies of treatment like metformin alone, or insulin followed by metformin, incretin followed by metformin, or now we have the bariatric surgery. You actually target the obesity, bring down rapidly the blood sugar and other things, and see what happens. There are also lifestyle measures very eloquently presented by Dr. Makkar. Diet is something which is very difficult to quantify, but exercise is something which is easy to quantify. And then obviously the behavioral pattern, the sleep pattern, and so on. I will very quickly touch upon all these things. Now, this RISE consortium, actually looking at the pediatric and the adult, and also the adult surgery, the bariatric surgery, the indications for recruitment in the trial were almost similar. Of course, in the pediatric age group, there were slight differences, but by and large, the indications are the same. Now, one very important thing that we need to understand is, before I talk about the RISE adult, that what are the seminal differences between the youth with type 2 diabetes and the adult with type 2 diabetes, how they behave differently, and I think this is a very interesting study. And all the 5 or 6 studies that I'm going to talk very briefly are based upon same thing. You go through 2-step hyperglycemic clamp studies, and you look at the insulin sensitivity, number 1. Number 2, you look at the acute response of C-peptide and insulin within the first 0 to 10 minutes. And then you look at the steady state, and a steady state C-peptide and insulin response at a glucose level of 200 milligrams per deciliter. And then finally, arginine is stimulated response of C-peptide and insulin at a blood sugar level of 450 milligrams per deciliter. So that pattern will be reflected in all the results I am going to show to you. So now let's start with a number of, let's say 66 young patients with type 2 diabetes and 355 adults, subject them to these 2 steps hyperglycemic clamp studies, and look at those parameters which I just mentioned to you, and the results will be very, very smart. Now look at this. The A, B, and C, they are actually depicting to you the glucose level, the C-peptide level, and the insulin level. And what you see, that irrespective of the fact that which group you are talking about, you have the same pattern. But when it comes to the C-peptide and insulin response, in the youth, you clearly see the difference. And what does it tell you? That's a very important conclusion to make. That younger patients, even though have lower insulin sensitivity, but their C-peptide response, their response to glucose is much more brisker. That means they have better residual beta cell function. Then you move on to D, E, F, and there once again you see the difference between those who had IGT versus frank diabetes. And that's not a big brainer to understand that IGT patients will have a better C-peptide or insulin response. When you come to adults with diabetes at the lower panel, G, H, and I, once again you see that the insulin sensitivity is not as badly affected as in the youth population, but the C-peptide response is certainly deteriorating over time, as you can see from the left panel to middle panel to the last panel. So obviously, the conclusion of this group of studies is very simple. I am not going to read everything which is written on this slide, but suffice it to say that youth with type 2 diabetes have lower insulin sensitivity, adults have higher insulin sensitivity. But youth have better insulin response and C-peptide response, and adults have diminished C-peptide and insulin response over time. That would be a very important target to understand that how we can prevent. Now, can we reverse this process by giving 2 strategies? One, metformin alone, and remember, all these patients are either pre-diabetic patients or newly diagnosed type 2 diabetic patients. Or, shall we give first insulin for 3 months and then followed by metformin for 9 months? And look at the difference between these 2 strategies. And once again, you are measuring all those things, measures of insulin sensitivity, first 10 minutes of acute response of C-peptide and insulin, then a steady state at 200 milligrams of glucose, and then arginine is stimulated 450 milligrams of glucose. And then it doesn't matter which strategy you are talking about, you have excellent HbA1c and glucose control up to 12 months, but the moment you withdraw, whether the metformin alone treatment or the insulin plus metformin treatment, the results are exactly the same. So what we are clearly seeing here, that it doesn't matter which strategy you are choosing to prevent diabetes, it works until you are giving the treatment. The moment you stop the treatment, over a period of time, the blood sugar starts going up, the C-peptide and the insulin response is progressively deteriorating with increasing duration of diabetes. What about the gastric banding? The surgery has now promised that in many cases there is reversal of diabetes, there is remarkable reduction in the need for insulin and oral anti-diabetic drugs. Can we do that by doing this? And this study, the gastric banding was actually compared with metformin, and both of them were given for 2 years. And when you look at the glycemic parameters, obviously again, not a big brainer to understand that gastric banding gives you a much better reduction in the body weight, the HbA1c, etc. But at the end of the study, when once again you look at the C-peptide response and insulin response, at the end of 24 months, there isn't a big difference. So even bariatric surgery as a modality of prevention of diabetes at this point of time is not something that we should be chasing for. We should be clearly understanding this fact that we need something more, maybe at the genetic level or something, we don't know. But the most important is the physical activity which we just learned, and once again what we are doing here, looking at adults with IGT or newly diagnosed type 2 diabetes, and what is very simple to understand, that the highest grade of physical activity on the left panel, as you can see here, gives you a better insulin sensitivity. That is very easy to understand, but that doesn't help in the beta cell response. You can see here, there is still a progressive decline in the beta cell response. Doesn't matter how intensively you are doing the exercise. So again, a little bit of, discouraging result. And then finally coming to the pharmacological interventions with the drugs which we treat our patients day in and day out. And this is a 4-armed study. The first arm is 1 year of metformin. The second arm, as I said earlier, 3 months of insulin, basal insulin, followed by 9 months of metformin. And then the third arm here is liraglutide for 2 months, then followed by metformin, and it's a placebo control. The fourth arm is placebo. Now, unfortunately, even in this particular trial, when you look at the results at the baseline at the end of 1 year, and then stopped the treatment for 3 months and looked at the results at the 15 months, once again, extremely discouraging. There are differences at the end of 12 months, and the basic difference is that the best response that you get is the combination of liraglutide plus metformin. But the response is there only until you give this combination. The moment you stop, you look here, very smart reduction in the body weight with liraglutide, which we know that it is responsible for a very good reduction in the body weight. But once again, when you stop the treatment, you can see there is a gradual upslope, and you lose that advantage which you had during the treatment phase. So once again, it doesn't matter. Of course, out of the 4 arms, the liraglutide metformin arm gives you the smartest reduction, the best C-peptide response while on treatment, best insulin response while on treatment, but the moment you stop treatment within 3 months' time, they all come back to the same stage. So it basically tells you that you can have a hierarchy of treatment modalities to prevent remission in type 2 diabetes, but the bottom line is that you have to continue giving that intervention. If you want to give it an incretin plus metformin, that's fair enough, but it wouldn't make a big difference the moment you stop these modalities of treatment. And finally, the last one, does sleep matter? A good quality of sleep, whether it is going to affect the glycemic parameters. Now let us look at that. The only conclusion that we can draw from this particular very extensive study is that if you have, something like a U-shaped curve, when you have sleep which is less than 5 to 6 hours, or when you are sleeping more than 8 hours, these are the 2 areas on the left panel you can see, they are associated with the worst outcome of glycemia. So this is the conclusion. This is a very complicated study. We will not go into the details, but suffice it to say that this is the message which is coming out from this particular study. So ladies and gentlemen, I would like to conclude my talk by telling you that deterioration of beta cell function happens progressively in type 2 diabetes. It is inherent nature of the disease, and any treatment strategy, including lifestyle modification, can preserve or improve the beta cell function or insulin sensitivity only until you carry on with the treatment. The moment you stop that intervention, that benefit disappears. And this is extremely important, and whether you are talking about the lifestyle intervention, good quality of sleep, pharmacological intervention, or even the bariatric surgery. Thank you very much for your patient listening.